Okay, welcome everybody. Thank you for joining us today for our Health and Action Work Group presentation. My name is Rachel. I am one of the site engagement coordinators with MVC, and I am happy to be here to facilitate the work group for you today. We're going to start with our agenda, kind of go through what we're going to be talking about today. First, we're going to go through our normal housekeeping and some P4P credit reminders. Um, And then we'll have a presentation, a brief presentation, kind of a review of the how should we measure system quality with our MVC team member. And that will be followed by some breakout sessions that will relate to the part of the presentation. And we're hoping for some really great engagement and active and participation with that. And then following the breakouts, we'll just go over some of our upcoming events and updates. All right, so first reminder that we do record these sessions. These slides and recording will be shared with attendees after the work group. We send that out via email, along with the survey, the post work group survey link for anyone who would like to fill that out and give us feedback. Just another reminder to please mute your microphone if you're not asking a question or being a part of a discussion. That helps kind of reduce the background noise. And then if you have questions throughout the presentation and you don't feel like you can talk, you can always put them in the chat. We'll have our MVC team kind of monitoring the chat for those so we can follow up on the questions there as we go. A reminder for our P4P participating sites that we do require active participation throughout the work group. That includes staying for the meeting for at least 75% of the time, answering any of the polls and discussion questions, and then participating actively in our breakout discussions. And then following the work group, we do require that you fill out the post-work group survey to receive your engagement points. But anybody who attends, whether or not you're part of the P4P program, can fill out the survey just to give us your feedback. We love to hear from everybody on their thoughts and what they liked or what they didn't like. All right. So today's presenter is Dr. Hari Nathan. Um, and he will be kind of continuing his presentation from our Spring Collaborative Wide meeting on measuring quality in systems. So I'm going to pass it over to you, Dr. Nathan.
Thanks, Rachel. Welcome, everyone. Thanks for joining us today, and I'm looking forward to a productive discussion. So over the next couple of slides, I'd just like to do a little level setting and review some of the concepts that we talked about at the recent semi-annual and kind of lay the groundwork for the discussion to follow. So these are my disclosures, one of which is relevant to this presentation because we have a grant essentially studying some of these concepts. So some of what we focused on at the recent semi-annual was an overview of some of the kind of landscape and the data on health system consolidation. So over the last 30 years or so, there's been an enormous wave of consolidation between hospitals in the United States to the point that about 70% of American hospitals are now part of a larger system as opposed to standalone hospitals. And those systems are as different as you could imagine. If you've seen one, you've seen one. And they range anywhere from one hospital together with perhaps a physician organization or some outpatient practices to large systems that may include hundreds of hospitals spanning multiple states. And one of the concepts that we've focused on the research side of this is that if we can understand how those different phenotypes of systems kind of correlate with their performance, we may start to understand some things about what makes a good system and what makes a system that's maybe not as high performing. Next slide. Okay. So in theory, there are several advantages of health systems that should lead to more efficient, more coordinated care with better outcomes for patients. So the first of these is rationalization of sites of care. And what we mean by that is essentially right sizing the intensity of care that's provided to the complexity of the patient and the complexity of the care they need. So one example of this would be to think about having surgery at a large tertiary inpatient hospital versus having surgery at an ambulatory surgical center or even an outpatient clinic. Depending on the patient's comorbidities and how complex they are, and depending on the procedure that they're having, one of those might be more appropriate than the others. And as a result, if we can appropriately select the site of care for each patient, we can overall achieve cost savings by not treating patients at a more expensive site than what they need. Internal selective referral is another potential advantage. And so you can imagine that as opposed to a standalone hospital, a system that might include multiple hospitals, multiple specialty groups, and that might include outpatient clinics, even post-acute care facilities, et cetera. Um, One could essentially get the patient to the right provider much more efficiently, at least in theory. Avoiding low volume surgery. So there's a large body of literature that shows that for complex surgical procedures, hospitals and other facilities that do high volumes of these procedures have have better outcomes and lower rates of complications. Despite this, we know that overall, that many hospitals still perform these complex procedures at very low volumes, and somewhat predictably, that results in more complications, more mortality, and higher costs. In theory, health systems should be able to avoid this by shunting those complex procedures away from their lower volume hospitals and into higher volume hospitals in the same system. Conversely, there are certain routine procedures where the focused factory model may be more useful. And if we think about procedures such as lower extremity joint replacement, where it's a fairly low complexity procedure, but it's a high volume procedure. And so, to the degree that a system can do that much more efficiently, and to the degree that it can generate kind of a high throughput site where patients are brought through in a very streamlined, protocolized fashion, that can be advantageous to everybody. Disseminating best practices. So you can imagine a system in which there are perhaps research institutions and community hospitals and everything in between, making sure that the best practices get disseminated throughout the system, making sure that patients have access to the latest clinical trials without necessarily having to always travel to the big research center can be useful. And then finally, another major advantage of health systems is an attributed population. So, kind of the holy grail in population health management is having a population of patients over which you have essentially both control and responsibility. And by using the various sites of care that are included in a system and kind of taking ownership of those patients, the hope is that these systems will be able to provide more coordinated care and more efficient care and result in better outcomes for patients over the long run. Okay, so there have been various barriers historically to the optimization of healthcare, regardless of whether we're talking about medical admissions, surgical admissions, or others. One of those is that the care coordination infrastructure has been historically lacking. Hospitals, are really have been historically standalone entities. They may not be able to communicate effectively with primary care providers and other specialists. And one of the advantages of systems is that there has been improving EHR integration and interoperability. There are greater resources available to facilitate tools such as telehealth. Overall, at least in theory, enhancing communication and coordination. So you could imagine having three, four, five systems in the same hospitals in the same system that now bring all of their EHRs under the same umbrella. And I know many of you are undergoing these kinds of changes right now. And although it's painful to do, eventually on the back end, we hope that that will facilitate better care coordination and communication. Second, attribution of patients, which I just referred to. One of the problems in the past has been that care has been very fragmented. And so a patient may get their primary care, through a private physician group. They may tend to visit one hospital for certain needs, but then they may go to a dialysis clinic that's perhaps under a different healthcare entity. And none of these entities really bear the ultimate responsibility for the overall care of this patient. Fragmentation is still an issue, to be sure, but one of the advantages of healthcare systems is that because they may provide all of those different services, there's a greater likelihood that they can keep the patient under their umbrella within their system for all of those different services. And when that happens, starts to become more fair to ask the health system to bear some responsibility for the health of an entire population that may be attributed to them. Another problem in healthcare is the lack of skin in the game from referring physicians. So, take the example of surgery, for example. I think every primary care doc or referring doc wants to refer their patient to a good surgeon, but ultimately, the outcomes that result from surgery, the expenditures result from surgery, are not really that referring doctor's responsibility. Well, again, in a system model where the referring physicians may also be employees of the health system, those lines of accountability change and become a little bit tighter so that now everybody has a shared incentive to make sure that we're providing the best possible care for patients, regardless of what they're undergoing. And then subsequently to hand that patient back and facilitate a seamless transition back to the primary care setting to make sure that that loop is closed and to minimize the risk of readmissions, ED visits, and other downstream utilization after a particular hospital admission, whether that's for a medical condition or whether that's for surgery. I mentioned a couple of minutes ago the issue. Oops, I think we lost half the screen there. Um, I mentioned a couple of minutes ago that we have a lot of data that suggests that it's not a good idea to do complex procedures at low volumes. But of course, in the past, one of the major disincentives to getting hospitals to send those cases that they do at low volumes to other competitors who do higher volumes has been that that's revenue that that hospital loses. Well, in a system context, if you have, for example, three hospitals, two of which do a low volume of complex surgery, such as say, pancreas surgery or cardiac surgery, and the third might do a very high volume. If those two low volume hospitals were to shift that volume to the higher volume hospital, it's not really revenue lost to the system because the patient is still undergoing care within the same financial umbrella. And so that hopefully removes one of the disincentives for referring care to the most appropriate place that has the best outcomes. Inequities in social risk and access to care. So over the last 5 years, especially, I think we've all grown to appreciate more and more how much of our healthcare outcomes are determined by things that actually exist outside the healthcare system in terms of the neighborhoods we live in, the food we have access to, the transportation we have access to, other issues such as that. And although these are still larger societal problems that transcend the healthcare system, care within a system context creates more opportunities to address these inequities in social risk and access to care. Again, simply having more sites to offer to patients so that, for example, those who don't have ready access to transportation may be able to access better care, utilizing tools such as telehealth in order to bring the care to the patients as opposed to always making them travel, and also facilitating meaningful investments in care coordination infrastructure and attempts to address some of these social determinants of health are something that many systems across the country are doing. Even though they aren't directly being reimbursed for it, they're able to cobble together that money in a way that an individual hospital would have a really hard time doing. Appropriateness is the last one that is difficult in terms of a barrier to care optimization. We still, in this country, have been very resistant to evaluating the appropriateness of care. And unlike many other countries where, for example, cost effectiveness analyses are part and parcel of approving any drug that's going to be reimbursed or approving any new procedure, we've tended to be very resistant to that in this country. And systems are not a magic bullet to deal with that. And so that's the one on this list that I think is still a barrier that we'll have to contend with that healthcare consolidation is not necessarily going to fix. Okay. So As we think about this problem and really this opportunity, I think there's a few things that, a few questions that I would put out there for your consideration, and hopefully these will start to jumpstart some of the discussion in the small groups that we're about to break out into. The first is what can we learn from high performing systems? And again, this is something that on the research side, we've been trying to work earnestly on to understand what systems that do things at a very high level in terms of efficiency, in terms of quality, in terms of maximizing patient access and convenience and patient experience. What are they doing differently than others who are not doing as good a job so that hopefully we create translatable lessons that others can learn from? The second is a big one, and that is how do we measure hospital system performance? So, if I ask you how do we measure hospital performance, all of you could give me lots of answers. Well, we measure mortality, we measure readmission rates, we measure episode costs, we measure post-acute care utilization, we measure transitions of care back to the primary care providers. But if we think about how one measures a hospital system performance, the answer is not really so clear. And in fact, there really are no widely accepted metrics for how we measure hospital system performance. What I mean by that is not just summing up the performance of all the hospitals that make up the system, right? Because that's not really asking the system as to function as more than the sum of its parts. What we're really trying to get at here is how do we measure that aspect of systemness, which means that there's something special about bringing together the ASC, the hospital, the physician organization, the primary care clinics, and they act as more than the sum of their parts. They're able to achieve something that those entities on their own would not be able to achieve. And putting your finger on that, trying to figure out what to measure is challenging. There are some ideas. Um, and I hope that the discussion will generate even more ideas because as MVC looks to measure and incentivize hospital performance, we really need to come up with metrics that everybody can buy into and that everybody agrees are in the patient's best interest and are feasible and fair for systems to aspire to. And so once we've established what those metrics are, of course, we need to think about how do we create the right incentives for hospital systems to improve quality and cost. And remember that most of our incentive programs in this country, whether we're talking about Blue Cross incentives in the state of Michigan or CMS incentives that are run through the Medicare program nationally, are still built basically on a fee-for-service infrastructure. And we essentially look at what you've spent based on your individual claims. We add it up, we see if it met some target price, and then we either penalize you or we give you a bonus depending on how you did. And that's largely done either at the physician level or at the hospital level. The question now is, of course, how do we do that at a system level? And again, I would challenge you to think about more than just how do we just add up the results of all the individual hospitals in the system, because that's not really behaving like a system. Nor do I think we should simply take the average of what's happening in the system, because the danger there is that the few biggest hospitals in the system essentially dominate the average, and you can almost hide bad results at your smaller hospitals within those averages. So the challenge is to really figure out what's meaningful in terms of challenging a system to act like a system, to really leverage these different sites of care, to leverage their breadth and their depth of experience in order to provide the most appropriate care. That's not always the cheapest care. That's not always the least resource intensive care, but rather matching the intensity of care and the site of care to the needs of the patient to achieve the best results at the most reasonable, not necessarily the cheapest, but the most reasonable price. And then finally, I think system healthcare systems and hospital consolidation present an opportunity to address equity in care delivery. Probably the simplest example for me to wrap my head around in this space would be if you think about patients in rural areas who may have limited access to specialty care, if their critical access hospital or their local clinics have been absorbed into a larger system, that all of a sudden opens up a lot of opportunities to get evaluation by specialists, to get plugged into different telehealth services. I mean, in our own institution at Michigan Medicine, I see lots of patients in rural areas of Michigan by telehealth. And so we're able to make a surgical evaluation with them without them needing to drive the 7 hours from the UP down to Ann Arbor, for example. And that's something that would not have been available to them even just 6, 7 years ago. And so these are the kinds of opportunities that integration into systems can potentially offer. But I have to say that despite all of these potential advantages that I've talked about, and all of the promise of healthcare systems to address some of the historical barriers to care optimization, most of the available evidence suggests that systems really aren't doing these things yet. And so again, part of why we want to start thinking about what are the right metrics to measure this idea of systemness. In other words, how is the system really behaving in a way that takes advantage of having all these different services and facilities under one umbrella? How are we challenging systems to act as more than the sum of their parts? Part of the reason to develop those metrics is to really challenge them to rise to the occasion and to do these things. And one of the ways in which MVC is going to be seeking to do that is by creating incentives through our P4P program in order to reward those systems that really are making those investments and really are putting those processes in place to take advantage of these unique advantages that systems have. So what I would challenge you all to think about as we move into the small groups is what is your organization doing at a system level that you would want to be measured on and or receive credit for improving? And you don't have to necessarily be able to figure out exactly how we would measure it. But I would encourage you to think in terms of things that likely could be measured using claims data. In other words, internal communications within a system that are being sent to all the constituent hospitals probably aren't the kind of thing that we're going to be talking about here. Rather, we're going to be looking at things that really will manifest in the data. So, for example, perhaps how different are the outcomes at the five hospitals in your system for a given diagnosis or a given range of diagnoses, right? How different potentially is the spending? How different is the post-acute care utilization? How effectively are you triaging patients, who are undergoing outpatient surgery as to whether they can undergo that surgery at an ASC, which generally is cheaper, or whether they really need to have surgery at the flagship hospital, which generally is going to be more expensive, right? So how do we measure those kinds of things that really are incentivizing systems to kind of take a population level look at how do we optimize the resource allocation and the expenditures to make sure that we're giving patients what they need, but that we're not giving them more bells and whistles than what they really need in order to have a good outcome. So at the recent collaborative-wide meeting, when we brought up some of these topics, the top collaborative-wide meeting answers were the ones that you see here. Um, any of the CMS five-star measures. Again, the question there, of course, is how do we measure that at a system level, given that these CMS measures are awarded at a hospital level? Balancing length of stay and readmissions. One of the aspects of systemness that one might think about in that respect is that, especially within a healthcare system, a discharge from a given hospital, um, if that patient needs a readmission, may or may not need to happen at that same hospital. Perhaps there's a facility closer, or perhaps by facilitating follow-up care at a more nearby clinic, that readmission can be avoided altogether. Infection prevention and sepsis outcomes, including length of stay, readmissions, and mortality and end-of-life care. So as we break into small groups, we're going to be talking about these topics in order to kind of brainstorm additional ideas about what systems are doing, what you are doing, or what you've heard of others doing. And then if you can think about how we might measure that, that would be helpful. Although I don't want that to be a barrier to the brainstorming. So if you're not quite sure how we would measure it, that's okay. Put the ideas down and let us worry about that. But if you've got an idea, we certainly welcome it in terms of how we might measure it. Okay, so these are the topics. Is this the last slide, Rachel?
Yeah, this is going to be the poll question that people will answer, and then we will they'll get assigned to the breakout room based on their answer.
Everybody should see the poll now, so
Yep, and thanks everybody for your attention. Look forward to hearing back from each group about what ideas you generate.
once we have about close to 100% answers, then we'll go ahead and go into breakout rooms based on your selections.
Okay, welcome back, everybody. Hopefully everybody had a great breakout session and discussion. Did we get everybody back? Okay, looks like it.
Yeah, it looks like everybody's back now.
All right, cool. All right, so we'll just do like a quick wrap up. If there's any remaining questions people might have, or comments about their discussion, that would be great to hear. Or if any of our leads from the different breakout sessions have anything they want to kind of recap, that would be great.
I just want to call out, I know we didn't give a chance for questions for Dr. Nathan, so this is also a good space if anybody coming out of your discussions still has questions for Dr. Nathan's presentation. Um, and I'll let Rachel.
Well, we were in the infection prevention group, and we probably could have used another hour. But we did, have enough time to get into a few tidbits, and we heard from three different system representatives, all of whom have some kind of centralized um, infrastructure for monitoring infection rates of different types at their various member hospitals, and all of which have a process in place to identify um, infections when they occur or high rates of infections when they occur, and to kind of then drill back down to figure out what's going on. Um, and so, now we may not have heard from those who perhaps don't have a centralized infrastructure. And I think that's something that we can maybe do a little bit more digging into, because um, one of the things that I think we could look at in addition to just performance in terms of the rates of infection is process measures like that. So I could imagine, for example, as part of a system-wide incentive, simply asking the question, do you have centralized QI infrastructure that monitors outcomes at your constituent hospitals with these attributes, 1, 2, 3, 4, 5. And if you're doing those things, you get credit. And if you're not yet, then we were going to challenge you to do it to get that credit. And that might be complementary to actually measuring the absolute infection rates themselves. So I appreciate the input of those in our group who had a chance to share.
Awesome,
We had a
thanks.
similar experience, I think, in our group too. So that tells me that there's plenty of room for some more follow-up discussion on maybe these topics individually as well. So thank you all. I know we're getting close to time, Rachel. I'll let you help us wrap up.
All right, thanks. Okay, so we are going to move on to our upcoming events. We have some work groups coming up. Our next one will be a rural health work group on Tuesday, July 8th. This will feature a discussion on introducing a sepsis compliance initiative in a rural health ED. Then on July 24th, we will have a post-discharge follow-up work group, which will include a presentation on a quality initiative to improve patient satisfaction and post-discharge planning in a smaller acute hospital setting. And then August, we have pre-op testing and health in action, and then September, sepsis and health in action. If you'd like to register, the link for these work groups is going to be in the slides that will come through on the email later today. So feel free to sign up for any of those or all of them, whatever you like. And then looking forward, upcoming events. We do have the MVC QI survey that is currently live right now. We encourage all members to complete the survey and give some insight into what initiatives your site or system may be working on. This is due June 30th. That is the deadline to complete the survey. So we do encourage you to do that. P4P sites can earn engagement points for completing that survey and completing it thoroughly. We like lots of good information. And then just a heads up, we will have another virtual networking event on August 21st. Registration is open, and you should get information for that in the email following this work group. And this will have a rural health focus and critical access focus. And then headline, MVC is seeking presenters for our fall collaborative wide meeting. It's weird to speak about fall now, but it's going to be here before we know it. Our fall collaborative wide meeting is Friday, October 10th. It's going to be at the Vista Tech in Livonia, Michigan. And we'd love to have some presentation proposals from anyone. If you're interested, if you got something that you think would be great to share, we'd love to hear about it. So the link for that proposal form will be in the slides and then also in the email that we send out to you later. All right, so that is it for our updates. Thank you everyone for attending. Emily's going to be sharing our link for the post work group survey in the chat. So you can click the link there, but it will also be sent in the email following the work group later today. So don't panic if you don't click it while you're here in the Zoom. Thanks again and have a great rest of your day.